I will be talking about the understanding of the osteoporosis, and in this talk, I will be covering the overview of the osteoporosis definition, epidemiology, pathophysiology, and diagnosis. So it is very important topic, particularly in India, where it is a very neglected disease, and vitamin D deficiency is very common, and almost the onset of the osteoporosis is 10 to 15 years earlier than the Western population. And the standard deviation for the osteoporosis lies approximately 3 standard deviation below the normal. So that is the thing. And in view of this becomes a very important comorbid condition. And if a person suffers from the osteoporotic fracture, the chances of other fracture goes around 4 to 5 fold high, and that increases the mortality as well as morbidity of the disease. So what is the osteoporosis? If you go by the definition, it is a systemic skeletal disease where the bone quality and quantity is hampered, and it will lead to the loss of connectivity and decreased cortical thickness and increased porosity. And that's why these patients present with the low energy trauma, such as fall from the standing height, and the disease will be uncovered only if they are screened with the help of DEXA. And most of the places DEXA facilities are not available in our limited resource setting. So it is very difficult to diagnose this disease. So what about the disease burden? Around 200 million women are affected globally. 27% of the geriatric population are having this disease. Approximately 54 million US populations are having this disease, and in India, approximately 23 crore Indians are having this disease, where the vitamin D deficiency is common, and the fracture presents 15 years earlier. So what it does to the society? So it causes economic burden, it increases mortality, it increases the disability. It is one of the cause of the non-specific vertebral pain in the female, and the fragility fractures. So if you want to understand the osteoporosis, you have to understand the bone remodeling. This is very important. In a slide over here, you can see a diagram of the cortical bone, where the bone remodeling has been shown. Here you can see 3 zone: the cutting zone, reversal zone, and closing zone. Here the cutting zone comprises of the nerves and vessel, and the reversal zone where the differentiation of cell is occurring, and ultimately mineralization is the closing zone. But what is different from the cortical bone? Here the cortical bone remodeling unit, there is a unidirectional flow, while in case of the calcaneus bone, the same process occur in a reabsorptive pit, and there is a canopy over it. So here the process start with the osteoclast stimulation, and ultimately there is a activation phase, then reabsorption phase, and ultimately there will be a formation phase. So the process start with the osteoclast activation with the rank ligand, and ultimately there is reabsorption, and osteoporotic stimulate the osteoblast, and ultimately there is a trapped osteoblast forming osteocytes. And this is all about the bone remodeling, and where the reabsorptive phase is around 20 days and bone formation phase is around 120 days. So if you look at the stepwise, there is a activation phase, there is a reabsorption phase, there is a reversal phase, formation phase, and ultimately homeostasis. So you can see a lot of molecules which are playing a role in this process. Like if you look at the reabsorption phase, it is mainly controlled by rank ligand and osteoporotic axis. If you look at the reversal phase, the TGF beta and IGF-1 is the main player. In formation phase, you see that there is a formation of the collagen and collagen deposit, and it is being governed by different bone forming unit, and ultimately homeostasis occurs. So it is a altogether integrated feedback process, and there is most of the time bone remodeling is growing on. So how it is stimulated. Actually, the bone remodeling process start with the micro cracks and wear and tear forces on the bone. And once there is a micro cracks, there is apoptosis of this osteocytes, and because of this apoptosis, there is upregulation of ATP production because of the PY2 receptor, and ultimately there is a secretion of more and more Rang ligand. And because of this secretion of this Rang ligand, there is more and more formation of osteoclast from the osteoclast precursor. So here the stress process, wear and tear actually stimulate the osteoclast activation. And this form a micro environment where the canopy is there, and there is a recruitment of this macrophages monocyte from the bone marrow, and ultimately these bone marrow precursor cell transforms into the osteoclast, and there is a canopy formation and there is a reversal phase. So you can see here the pericyte, the osteoclast is activated once there is a active acidic environment below the teeth, which you can see the cell, the osteoclast are having small comb like appearance, or you can call it as a teeth. So here the acidic environment is there, and then the reversal cell is there below the bottom of the pit. And after that, there is a formation of the bone, that is the blastogenesis. What happens in osteoporosis is there is defect in osteoblast function. So bone formation is hampered. So be it glucocorticoid, be it myeloma, be it postmenopausal osteoporosis, alendronate, aging, every process actually inhibits the osteoporosis blast function, and ultimately there is weakening of the bone. So in the mineralization phase, what happens? There is a stimulation by the TGF-B, B1 and IGF-1, and that will lead to the cellular response and ultimately osteoblast recruitment and differentiation, leading to the mineralization. So the if you look at the center of the pathophysiology, the anabolic osteoblasts are at the fault, and they are the main architect of the bone formation. And if you correct these anabolic osteoblasts, then only you can treat the osteoporosis correctly. So they are mesenchymal origin cell. They respond to the WN2 beta catenin pathway and the PTH pathway and TGF beta. And if you give intermittent PTH anabolic hormone, they stimulate the osteoblast, and ultimately bone formation is there, and ultimately matrix production is there. That's why the anabolic drugs which are there are in form of PTH analog, or the drug which will inhibit sclerostatin, that will stimulate the osteoblast. In due course of time, we will discuss this, what are these targets. And till now, the main regulator of this osteoblast system is rank osteoprotegrin system. So if the rank is activated, there will be more breakage of the bone. If the osteoprotegrin is stimulated, there is more formation of the bone. So that is in one line osteoporosis pathophysiology, and different molecular regulatory pathways are there, and they are both bone forming as well as bone resorbing. These two-way communication are occurring very fast. So in nutshell, what we can understand is the balance between osteoclastic and osteoblastic activity is going to decide about the bone health, and this pathological imbalance between the osteoclastic and osteoblastic activity will ultimately lead to the osteoporosis, be it physiological, be it disease driven, be it drug driven process. All these things will lead to the osteoporosis. So let's discuss what about the risk factor of the osteoporosis. There are different modifiable risk factor and non-modifiable risk factor. We can always look at the modifiable risk factor because these are the factor we can intervene upon, like the hormonal deficiency, nutritional deficiency, smoking cessation, sedentary lifestyle, and glucocorticoid, anticonvulsant, and body mass. Lower body mass, higher body mass, sarcopenia, all these are the risk factor for the osteoporosis. If you look at the clinical presentation and the symptom, osteoporosis is a very silent disease, and hardly there is any signs and symptoms. but if you inquire specifically, you can get non-specific body pain, vertebral pain, or you can have a history of loss of height or development of the kyphosis. If these things are there, you can think of the osteoporosis. If your index of suspicion is very high, then only you can diagnose the osteoporosis. And osteoporosis will lead to the fractures. If the fragility fractures are there in the background of low energy trauma or falling from the height uh, 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 less than the height of that person, you will always rule out the osteoporosis and try to diagnose osteoporosis in this subgroup of patients. How to diagnose osteoporosis? The gold standard test is DEXA, and it is diagnosed on the basis of the T score. And if the T score is less than 2.5, it is osteoporosis. If the T score is associated with less than 2.5, associated with the fragility fracture, it is associated with highest risk category. At the risk of the fragility factor is 4 to 5 times high in subsequent uh, time. What is the Z score? T score is the age match score, while the Z score is the age match score, while the T score is the score compared to the adult healthy population. So if your age match controls are below less than 2 standard deviation, that is the Z score, it is a suspicion of secondary osteoporosis is there. You should go and find out different causes of secondary osteoporosis if Z score is less than 2. So if the T score is less than 2.5, it is osteoporosis. If the Z score is also less than -2, then you should look for secondary osteoporosis. And the in presence of fragility fracture, low height trauma, you can directly diagnose on basis of X-ray or on basis of clinical history itself. So the gold standard for the diagnosis is the DEXA. DEXA is actually 2D two-dimensional image by the X-ray. So actually it takes the density in the two-dimensional way, but our bone is in the 3 dimension. That's why different artifacts can increase or decrease the bone density. That is the one of the important limitation, but this is one of the most useful tests till now for the diagnosis of the osteoporosis. So if you look at the different clinical assessment things, you should always focus on age and sex, the body composition like low body weight or increased body weight, or presence of sarcopenia, history of fragility fracture, particularly the vertebral fracture, and history of smoking, alcohol, glucocorticoid intake more than 5 milligram per day for more than 3 months, or any fracture risk and person taking aromatase inhibitor, anticonvulsant, the PPI. These can cause dose dependent risk for the osteoporosis. You should also take a good history, and that will tell you the main thing. So initial evaluation, then imaging assessment, then additional testing. These are the tests you can go for. And apart from all these tests, fracture risk assessment tool is very, very important. One of the important scoring system is the FRAX risk scoring system. It is available online. So actually it gives 10-year probability of the fracture, and on basis of this you can diagnose the different osteoporosis. Apart from this, there are other calculators available, that is Garvan calculator, Q fracture. And if you compare all these things, the best is the FRAX, as it is country specific. It also gives the mortality risk. But the Q fracture, where the BMD is not required, are very important source for the resource limiting setting. This is the comparative table which is given over here. So what we can do in the assessment of the osteoporosis, go and calculate the FRAX risk score with the help of calculator if the BMD is available, or if the BMD is not available, still you can calculate FRAX risk score, and risk factor integration can be done. And always try to calculate the country specific parameter, and on basis of this you can diagnose osteoporosis. Are there any advanced machine available for the osteoporosis test? Yes, these are few machines which are now available, like the CT, MRI, and the peripheral quantitative computed tomography. All these are good modality, but having limitations and needs validation in the future. So once you have diagnosed the osteoporosis, you should give the treatment. But what is the role of biochemical marker in osteoporosis? Since the BMD is one thing which will diagnose, and it is the gold standard for the diagnosis of osteoporosis, it is not a good thing to monitor, because it takes approximately 1 to 2 years to have change in the BMD. So in that scenario, if you look at the bone formation marker and bone resorptive marker, these are very, very important if you are monitoring the bone formation and if you are treating osteoporosis case. So bone formation markers and reabsorption markers are very important in monitoring of the osteoporosis. So screening recommendation: if the woman age more than 65, they should be screened, or any postmenopausal woman with clinical risk factor or FRAX score more than 9.3 for 10 years, these in the DEXA, they should be screened. In the men more than 70 year or 50 to 69 year with secondary cause of bone loss, you can screen. Or any special indication with the vertebral deformity, hyperparathyroidism, chronic glucocorticoid therapy, adrenal insufficiency, organ transplant, hypogonadism, malabsorption, these are very, very important. And here you should go for DEXA screening, and every 1 to 2 year therapeutic monitoring can be done, and diagnostic, it should be done every 3 years. So what is the treatment? This is the last part. The lifestyle modification is very, very important, like exercise, fall prevention, smoking cessation, and alcohol is important, and giving strength to the bone, and it will give a mechanical stimulus also that will increase the bone formation. As giving only drug is not going to solve the problem, giving load on the bone will actually stimulate the bone for the bone formation. So shear forces are very important for the bone formation. And nutritional osteoporosis management is very important in form of calcium, vitamin D, protein intake 1.2 gram per kg, and other nutrition like magnesium, potassium, zinc, and phosphate are important. So as far as the pharmacotherapy is concerned, it can be divided into anti-reabsorptive and anabolic agent. And if you look at the pharmacotherapy of the anti-reabsorptive and anabolic therapy, they also differ in the form of quality of bone formation. Here you can see the anti-reabsorptive therapy reduce the bone remodeling, while the anabolic therapy, what type of anabolic therapy you are giving is very, very important. If the modeling based bone formation is there, if you are giving correct thing to stimulate both osteoclast and osteoblast, while if you are only giving the drug which is stimulating osteoblast, the bone architecture will be different. So anti-reabsorptive therapy is the bisphosphonate, denosumab, and selective estrogen receptor modifier. And if you look at the bisphosphonate, they are the cornerstone of the therapy, and they are most important agent in the treatment of the osteoporosis, because they are very rapidly available and the cost of therapy is less. So here the different type of bisphosphonate are there. My only point is all bisphosphonate are not same. And look at the ebandronate, they are acting only on the vertebral part, and other agents are actually acting on all three. While if you look at the requirement of the oral bisphosphonate, all are given orally, and they are important if you are giving this empty stomach, but rosindronate can be taken after meal. What about the denosumab? This is one of the drug which is IgG2 antibody against the RANG ligand, and it is very important, particularly the patient who are having CKD. These agents are very, very important. looking at the selective estrogen receptor modulator, these are the drugs which are very important for the female who menopausal, postmenopausal osteoporosis, female having hot flushes, having high risk for the breast cancer or endometrial cancer. Here you can give this agent because they actually protect from the cancer, and ultimately you will get increased bone mineral density also. And here this is the comparison of the all the selective estrogen receptor modulator, and you can go through with this table, and these are very important if the person is having hot flushes and leg cramps. What about the other anabolic agent, the teriparatide and abaloparatide? These are very, very important, and they actually only stimulate the osteoblast. While romosozumab, this is the anti-sclerostin monoclonal antibody, it stimulates both osteoclast and osteoblast. According to the FAME study, actually the vertebral fracture reduction was up to the highest, approximately 73%. So this is very, very important. As far as PTH PRP analog abaloparatide is concerned, this is also very effective agent, but the chances of osteosarcoma risk is very, very high. That's why it is not a suitable agent. So two anabolic pathways are there. One is WN2 pathway, another is the PTH RP pathway. And if your PTH pathway is stimulating, it is only stimulating osteocyte and osteoblast. Look at this picture. Only osteocyte and osteoclast is stimulated. Osteoclast is not activated. While if you look at the romosozumab, this is a WNT signaling pathway where the beta carotene effect is actually prolonged, and ultimately it is acting on the gene to cause bone formation. The major difference between the PTH and romosozumab is actually it stimulates both osteoclast, osteoblast, and osteocyte. That's why this drug is very, very important. What about the combination therapy of the osteoporosis? You can see different type of the anti-osteoporotic therapies are there, and you can combine all these things. One of the important approach is combining the anabolic agent with the anti-reabsorptive agent, and this is very, very important in terms of the clinical effect, as if you are combining the anti-reabsorptive drug along with the anabolic drug, actually anabolic window is increased. That's why you get better bone quality if you are using it sequentially. So here is the three option. One is rozumumab with denosumab, teriparatide with alendronate, abaloparatide with jolipepridone. If you look at different study, first is anabolic first, then anti-reabsorptive. This will lead to enhanced outcome. So
hello, sir. Can I interfere in between? Yes. Can you summarize it?
Okay. Last two slides.
Okay, thank you.
So this is one thing. There is a synergistic effect of the hormonal and mechanical bone stimulation. So what about the duration? Duration of the drug can be given for the BMD formulation and follow-up. Then multi-component program is required, and always rule out the secondary osteoporosis. So in spite of all these things, the challenges remain because most of them are undiagnosed. Treatment rate is approximately less than 20%, and DEXA availability is very less. In future direction, what we can get in the treatment of the osteoporosis, we can have different biomarkers like microRNA, which will help you to diagnose the disease in the early stage. Advanced imaging like trabecular bone scoring is available. Artificial machine learning based proteomics, genomics, and clinical parameter can be integrated to diagnose the osteoporosis at the early stage. And genetic markers will help you to design a therapy like which patient is going to respond better to the bisphosphonate, which patient is going to respond better to the PTH can also be find out. And if you are specifically blocking the rank ligand and sclerostatin, actually it will improve the outcome. And in special population like men, premenopausal women, and glucocorticoid induced osteoporosis requires different approach. So there are
sir, I think we are running out of time.
Yes,
also.
yes.
Sorry.
So this is the last one. So summarizing all these things, the conclusion and call for action is the patient outcome, the quality of life can be improved with this. Evidence-based practice should be there. The continuous education is required and proactive screening is required, and this will increase the awareness in the patient, and ultimately with the help of multidisciplinary team, actually you can deliver the results. So thank you very much. Thanks everybody for the patient hearing.